The following lecture is aimed for dental students, trainees, dental interns, junior residents of oral surgery and oral and maxillofacial surgery. In memory of my late parents, may Almighty merciful God rest their souls in heaven and peace. Please allow me to give a brief bio about the speaker. My name is Mohammed El-Shulkami. I'm a professor of oral and maxillofacial surgery at the Faculty of Dentistry, Suez Canal University in Ismailia, Egypt. This lovely city, which lies around 120 kilometers to the eastern of the capital, Cairo, in Egypt. It was named after the late great ruler of Egypt, Khedive Ismail, the one who did the opening ceremonies of the Suez Canal in 1869. I'm also the professor and the supervisor of the Oral and Maxillofacial Surgery Department at Faculty of Dentistry, Sinai University, Kantara campus in Ismailia. I also worked as a part-time associate professor at MIU University and MSA University for several years. I'm a visiting professor at the Faculty of Dentistry, Beirut Arab University, in the Oral and Maxillofacial Surgery Department in Beirut, Lebanon. I'm also the managing director of the Egyptian Dental Center, a multi-speciality discipline dental and maxillofacial center based in Cairo, Egypt. Our topic today is the management of zygomatic-maxillary complex fractures. What do we have here? We are going to discuss etiology, anatomical considerations, classification, and clinical examination, followed by radiographic examination, and last but not the least, management. Facial fractures are caused by several factors, among the top of which is the motor vehicle accidents, altercations, falls, sports-related accidents, and occupational accidents. What about the surgical anatomy? In general, the facial skeleton is divided into three areas, or three-thirds. The upper third, comprising the frontal bone area, and the lower third, which is the mandible, and the middle third, which is found in between. The middle third of the face is bounded by superiorly a line drawn from the zygomatico-frontal suture, passing across the frontonasal and frontomaxillary sutures to the opposite side zygomatico-frontal suture. And inferiorly it is bounded by the occlusal plane or the alveolar ridge of the maxillary teeth. Posteriorly it goes as far as the frontal bone above and the body of the sphenoid below. And here is a diagrammatic representation of the middle third. In the middle you can find in the yellow color the central midface, the maxilla and the nose, nasal bones, and on both sides you can find the lateral midface in the light blue color. And in general, there are facial buttresses which are responsible for support of the facial bones. We find vertical support buttresses and anteroposterior buttresses for facial support. In the figure number A, you can find the vertical buttresses, the pterygomaxillary one, and the zygomatic, and the nasomaxillary. And there is a posterior one regarding the vertical ramus of the mandible too. On the other hand, in figure number B, you find the anteroposterior buttresses. Number 1 is the frontal bone, number 2 is the zygoma, and number 3 is the maxillary one, and number 4 is the mandibular body buttress. Let's go to the classification of the mid-face fracture. It was first introduced by René Lefort in 1901. René Lefort was a French pediatric surgeon. He served in both World Wars I and II, and he did some experiments on cadavers, hitting them with heavy metal objects or wooden planks or whatsoever. Some authors find his experiments as unethical, but yet his classification still holds up till now. He divided the middle third or the maxillary fractures into three types. Lefort 1, the lower level fracture, or Guerin fracture or Guerin fracture. Lefort 2, the pyramidal or the subzygomatic fracture, and Lefort 3, high transverse of suprazygomatic fracture, which we call it craniofacial disjunction. Still, this classification had some limitations: inability to accurately predict reduction techniques, and sometimes there are asymmetric fracture patterns. But until now, René-Lefort classification is still valid one. Let's see the Lefort-1 fracture. It's a transverse fracture which passes through the maxillary sinuses and the lower nasal septum and back to the pterygoid plates, and so it separates the maxilla from the pterygoid plates and the nasal and zygomatic structures, which leads to a free-floating palate. What about Lefort-2? Lefort-2 is regarded to as an oblique pyramidal fracture. It crosses laterally the zygomatico-maxillary sutures and the inferior orbital rim and the nasal bridge, which leads to separation of the maxilla and the attached nasal complex from the orbital and zygomatic structures, eventually leading to a free-floating maxilla and nose. Lefort-3 fracture, it results when horizontal force is applied to the level superior enough to separate the naso-orbital ethmoidal complex and the zygomas and the maxilla from the cranial base, and hence we have the term craniofacial separation or craniofacial disjunction. The fracture is above the zygomatic arch. It passes through zygomatico-frontal suture, through the lateral and medial orbital walls and nasofrontal suture, which leads to a free-floating face, and thus we call it the craniofacial disjunction. And here is a diagram representing the three fractures, starting from the left side, Lefort-1, going to the middle, Lefort-2, and going to the right side to Lefort-3. Sometimes you have the maxilla coming in a comminuted fracture. Now let's go to the Rose and Kelly classification. In 1968, they did the one for zygomatic fractures. It consists of 8 types. Type 1, where there is no significant displacement, and type 2, it's fracture of the zygomatic arch. Type 3, where there is rotation around the vertical axis. You can find the inward displacement of the orbital rim or outward displacement of the orbital rim. Type 4, it's a rotation around longitudinal or horizontal axis, where you can find medial displacement of the frontal process, lateral displacement of the frontal process. In type 5, there is displacement of the complex en bloc, which may be medial or lateral or inferior. In type 6, there is displacement of the orbital floor, and in type 7, there is displacement of the orbital rim. Last but not the least, type 8, where we have the complex comminuted fracture. What about the clinical presentation? Please don't panic. This is a typical presentation of a facial traumatized victim. We have some general signs and symptoms, usually pain, edema, ecchymosis of the cheek, ecchymosis of the eyelids, and paresthesia of the cheek due to involvement of the infraorbital terminal branches. On extraoral inspection, you find the typical raccoon eyes appearance. It's also known in the UK and Ireland as panda eyes. And anyway, regardless the name, it describes periorbital ecchymosis around both eyes, and it's considered as a sign of basal skull fracture or subgallial hematoma. Intraorally, there is floating maxilla, impacted orthoscopic fracture. You always find a disturbed occlusion and anterior open bite due to the gagged posterior molars. There is premature contact, and a classic open bite anterior open bite appearance will be noticed. You might find also ecchymosis and the cracked pot sound, mid-parietal split in some cases, luxated teeth, loose teeth, and damaged teeth. And last but not the least, Guerin's sign or Guerin's sign. It is considered as ecchymosis in the region of palatine vessels, as seen in the right side figure. And here is a very nice test and examination. You can detect whether this is a Le Fort 1 or a Le Fort 2 or a Le Fort 3 fracture. Using both hands, you hold the premaxillary region with one hand, usually the right hand, and you put your finger on the nasal bridge while you are trying to grasping the maxilla and manipulating it and trying to move it. And then you put your hand on the zygoma as well, on the zygomatico-frontal suture. If you have any movement is palpated at the nasal bridge while you are moving your hand, a Le Fort 2 or 3 fracture is present, usually. And if you have a movement detected with your other hand on the zygomatico-frontal or the zygomatic area, this is typically a Le Fort 3 fracture. And if there is no motion detected on the nasal bridge or on the zygomas, usually you have a Le Fort 1 fracture. There is a very important sign come in association with the Le Fort 3 fracture, which is the CSF rhinorrhea, leakage from the CSF from the nose. It can be detected easily from what we call the double ring or the halo sign. If you put this secretion of filter paper, CSF is easily can be mixed with blood while coming out of the nose, but when you place it on a filter paper, there is going to be a separation and a detection of this halo. CSF rhinorrhea is a sign of a craniofacial disjunction. William Henry Battle had introduced what we call the Battle sign, which is bruise or ecchymosis or blood collection over the mastoid process behind the ear. It is indicative of posterior cranial fossa fracture of the skull, and it might suggest there is underlying brain trauma as well. And let's always remember the 4 B's. Battle, bruises are seen, it indicates basilar skull fracture, and it is always behind the ear. And to wrap it up, there are typical 6 signs which denotes the base of the skull fracture, which are raccoon eyes, CSF rhinorrhea, and CSF otorrhea, presence of Battle sign, hemotympanum or bleeding from the ears, and last but not the least, you find a bump in the face. And here comes the turn of radiographic examination. The CT scan is the gold standard for middle third and facial fractures in coronal or axial or 3D images. You will find it very useful. Let's look at the upper right hand view denoting the fracture lines of Le Fort 1 and the lines you should find in Le Fort 2 and the lines of fracture in Le Fort 3. On the left hand you can find the classic submental vertex, which is the one done for zygomatic arch fractures. Find the arrow pointing to a zygomatic arch fracture, and on the right hand you find a 3D reconstruction showing a maxillary fracture and a mandibular parasymphyseal one. And thanks to the technology and softwares, we are lucky now to have a very good 3D images rather than the older ones. You can see on the left side in 1989 the images looked like that back then, and in 2004, and now we have far much more better images and image quality enhancements. When the word management pops up, we think for a few seconds, what are our objectives? Our general goals management are rapid bone healing, uneventful rapid bone healing, acceptable facial and dental aesthetic results, and last but not the least, restoration of normal function. And to achieve this, we have to follow the classic protocol: reduction of the fracture, fixation, and last but not the least, immobilization. And I think now that we have learned by heart that reduction may be open or closed. Open, that is to get a surgical access direct to the fracture lines and put your fixation methods, whether wire or plating or screws, and you do it on an anatomical basis, but after establishing of good occlusion in the teeth bearing area. While the closed, that you rely only on the occlusion and you put the maxilla and mandible in IMF or MMF relationship in the normal occlusion way. First of all, let's think, what is the proper timing for intervention and treatment of facial fractures? In general, it is always better to treat it as soon as possible. So when you ask yourself what is the proper timing, it is as soon as possible. Because any delay for several days, it will make the anatomical reduction of the fracture very difficult, or it may make it impossible. And the evidence has shown that the longer the open or compound wounds are left, the more incidence of infection and malunion will occur. Additionally, edema progressively worsens over 2 to 3 days post-injury, and it frequently makes the treatment of the fracture more difficult. However, the treatment of facial fractures is always or frequently delayed for several reasons. In many cases, the patient have other concomitant injuries that demand more immediate treatment, and they are more far important than dealing with facial fractures. For example, any patient sustaining a severe neurological trauma that precludes pre-surgical stabilization, and the patient can have an increased anesthetic or surgical risk, this should obviously be managed first before going into the OR and managing the facial fractures. And if you have a delay, as we said before, for 1 or 2 days, it might result in the presence of tissue edema, and this will make you wait for further 3 to 4 days necessary for elimination of the edema, and make it easier for you to go and do fracture treatment and fracture reduction. Additionally, the plan for the treatment of most facial fractures is to begin with the reduction of the mandibular fractures, and then you work from bottom to top and you go more superiorly. Bone repair should always precede the soft tissue repair. You should do the bone fractures and the bone trauma first, and then you close the soft tissue lacerations and injuries. But remember always the golden rules. Regardless the type of facial fracture or the surgical approach used, or the way or the type of the hardware used, the main goal should always be maintenance of proper occlusion. In the teeth bearing area, you should regard, and the hallmark is maintenance of a good occlusion, to have a good aesthetic appearance afterwards and to have a good function. So when you resort to the classic closed reduction and MMF, and you put the maxilla and mandible in good occlusion, you are lucky enough to have that, and then you put them in MMF. What about if the mandible is trying to move? It is going to dislodge the maxillary fracture as well. So that's why we resort to what we call suspension wiring. We use wires attached to the maxillary arch bar or the mandibular arch bar, and it is suspended to certain structures in the face. Number one is suspension from the frontal bone, and it is used in cases of the 4-3 fracture. Number two here is using the piriform rim to suspend the wire and or suspend the maxillary arch bar. And number three is using a suspension wire from the infraorbital rim. And last but not the least, number four, which is suspension from the zygoma over the zygomatic arch. And here is simply how can we do the circumzygomatic suspension wire. We use the zygomatic bone awl, and we introduce it extraorally, just posterior and medial to the zygomatic bone, and it emerges in the buccal sulcus in the first molar area region, and then you thread your wire, and then you pull it upwards, and then you try to pass the bone all over the zygoma and then emerge once more in the oral cavity with both ends, and then you have both ends of the wire are going around the zygoma, and then you twist it and tie it up to the maxillary arch bar. And this is how you put a per-alveolar wiring using what we find on the right hand, the maxillary of Gieser bone awl, and utilizing the cancellous bone pattern of the maxilla. You can pass it in the canine region from the buccal to the palatal, and then you thread the wire, and then you come back with the wire from the buccal side, and then you can tie your splint or whatever you would like to on using this wire, and you can put both wires bilaterally. And on top of this view, you can find on the left side the mandibular bone awl, and on the right side the handle and several ends of the mandibular bone awl. And when you do a circummandibular wiring, you introduce the mandibular bone awl lingually in the floor of the mouth in the canine region, and then you thread the wire and take the wire, and you then go downwards around the mandible, and then you emerge from the buccal sulcus, and then you have both ends in the oral cavity, and you can twist them, as you can see on the lower left figure, over the splint or over the patient's denture to use it to fix up the fracture. And of course we have to be very thankful for the microplates and screws, and here is a figure. You can see the screws and the plates in regard to a penny. You can imagine the size of them. They have saved us the hassle of the MMF and the suspension wires, and you can use them directly, and you can bend them easily intraoperatively, or sometimes you can use the stereolithographic printed model, and you pre-bend them prior to the surgery, and then you can go and reduce the fracture and fix them as well. On the right hand side, you can find a tripod or a 3-point fixation of the zygomatico-frontal suture, and the zygomatic and maxillary, and on the third one on the zygomatic and the nasal bone. You can also resort to a 2-point fixation, one on the ZF and one between the maxilla and the zygoma as well. Whatever works in your hands, you can do it. Another view here, you can find different types of plates, 5 holes, 6 holes, the L shape, the Y shape, or the T shape. You can use them according to the case. Nowadays you can find this nice polygalactic acid or resorbable plates. They are usually spared for children or in some difficult cases, but let me tell you that the manipulation of such plates is more difficult and more problematic than the metallic ones, and the cost, of course, is very high. Another case here, the fracture is reduced and fixed using 4 plates, 2 on the right side and 2 on the left side. What about the surgical approach to the facial skeleton? We have the classic upper vestibular incision. It is usually like the one we did in the mandible. You leave about 5 millimeters above the mucogingival junction. For this freely unattached mucosa, it's going to help you to suture back your flap, and then you go to incise, and then you go up. You can use this vestibular incision, and you can dissect up to the infraorbital foramen and the inferior orbital rim. This is Gillies' approach. It's an extraoral approach in the temporal area, in the hairline. It is usually 2 centimeters in width, and it is situated or put 2.5 centimeters above and anterior to the helix. And it is used, you introduce a flat, broad flat periosteal elevator, and you use it to reduce the fractured zygomatic arch. And usually the zygomatic arch doesn't need fixation. It's just only when you reduce it, it doesn't need the further fixation. Another intraoral approach to the zygomatic arch, it's called Keen's approach. You can look at the upper figure. You do a vestibular incision, and then you introduce your broad periosteal elevator, and you reduce the zygomatic arch or the zygomatic complex, and if you need fixation you can go and do it furthermore. Here is a very broad approach, the coronal approach or bicoronal approach or the bitemporal approach. It is done from side to side, and sometimes you can look on the right hand side, you can extend a preauricular approach or a preauricular extension if you want to expose the TMJs and the condylar area. The following areas can be exposed using the coronal approach: the entire calvarial vault, anterior and lateral skull base, the frontal and ethmoidal sinuses, the zygoma and zygomatic arch, the lateral cranial and medial aspects of the orbit, nasal dorsum, and last but not the least, the temporomandibular joint, condylar and subcondylar region. And in order to protect the temporal branch of the facial nerve, the superficial layer of the temporalis muscle is divided obliquely in an oblique line, starting at the tragus downwards and going upwards obliquely until the supraorbital ridge, and this enables the surgeon to enter the temporal fat pad. Below this fascial splitting, dissection is done and carried in the fat pad just deep to the superficial layer of the temporalis fascia until you can reach the zygomatic arch and the zygoma are exposed and reached subperiosteally. And here is a clinical view for a bicoronal flap, and you can find the plates are secured in place, and on the right hand you can find the post-operative classic 2D X-ray. And regarding the post-operative X-ray, you can resort or you can rely on the 2D views and save the patient money and radiation exposure. When you want to expose the ZF suture or the zygomatico-frontal suture, you resort to the lateral eyebrow incision. It is placed at the outer aspect of the eyebrow. The skin of the eyebrow is tented over superior orbital rim, and 1.5 incision is made in a beveled fashion, and it is parallel to the hair follicles. Then the skin incision is retracted over the zygomatico-frontal suture or orbicularis oculi muscle fibers incised overlying this rim. And we should always avoid shaving the brow hair. And in case the vestibular incision didn't give you good access, or should you need more wider access to the infraorbital region, you can use the infraorbital incision, or if you need it to be less conspicuous or less visible, you can resort to the subciliary incision or the subtarsal incision. Nowadays, softwares and printing of stereolithographic models and using of navigational surgery is gaining much more interest and much more popularity. We can use the tracker or adhesive thing fixed to the patient's head and the probe on the left hand side, and you can use the camera or the localizer on the right hand side on top of this image. It acts like the satellite. The whole system is like the GPS localization system. So the localizer, it acts like the satellite, while the probe is like the GPS found in our cell phones or cars, and the CT of the patient is like the road map. So you can use the probe, use your probe while you move during the surgery, and you can find the position of the probe on the screen. And here you find in the red color the corrected bone position rather than the optimum bone position in the white color. And you can detect when you put a mesh or to reconstruct the orbital floor, you can detect how far it goes posteriorly, how far it goes laterally, how far it goes medially, and you can have a very good appreciable accuracy regarding the manual approach. And finally, I would like to thank you for your kind attention. Thank you so much.